I have been prescribed and have taken numerous narcotics and opioid medications since late childhood to early adolescence underneath the guidance of my physicians. Just because I take those meds doesn't make me a drug addict. Hello y'all, and welcome back to my channel. If you don't know me yet, my name is Christelle. I'm an aspiring physician scientist. I am a sickle cell patient and a recent transplant survivor as of, 8 months and a week ago. I'm so excited. Today I want to talk about and dispel myths, misinformation, and disinformation about patients with sickle cell and their narcotic use habits. There is a common misconception that patients with sickle cell disease are addicted to the pain medications, the narcotics, the opioid medication that they need for their pain relief, and that when they go to the hospital, they're actually just drug seeking instead of actually being in pain. Let's dive into why that's not true. So I have a few key points to address, and the first one being almost every single patient with sickle cell will at one point in their life require the use of opioid or narcotic medication for their pain relief. Sickle cell disease, if you don't know, is a chronic and inherited blood disorder that causes extreme and severe pain. It causes a whole host of other organ dysfunction, but acute and chronic pain is a hallmark of sickle cell disease. So if a disease that causes excruciating pain over time, at some point, a patient with that condition is going to be expected to require some sort of pain relief. And Tylenol and ibuprofen, Aleve, over-the-counter medications are helpful in mitigating the inflammatory component of pain management and the inflammatory component of why we're experiencing pain as patients with sickle cell disease, but it alone cannot suffice to completely mitigate the extreme pain that we can get in our pain crises episodes. So to think that patients are drug seekers simply because they're asking for something that they pretty much need is kind of a double standard. It's a conundrum that we can never get out of. If every patient is going to require some sort of pain relief in that way, then you're kind of sticking us in between a rock and a hard place when we go and then ask for the thing because we do physically, clinically need it. Patients aren't seeking a high when they go to the hospital. They are seeking pain relief when they go to the hospital. And a lot of the times, patients with sickle cell disease will have pain plans that are curated by their physicians, by their hematologist, by their pain specialist, or their PCP. And it's really important to follow those guidelines. And a lot of those pain plans will include things like morphine, Dilaudid, fentanyl, Percocet, you name it. So there's no opioid drug that's off limits for use for a patient with sickle cell disease unless they're allergic to it. So my second point is that despite the fact that opioid use is pretty much necessitated in the medical management for patients with sickle cell disease, patients with sickle cell disease experience opioid use disorder at a less common rate than the general population. So there's this misconception that just because you take narcotics that you must be addicted, or if you take narcotics, it's going to automatically lead to addiction. And that is not true. Patients with sickle cell disease require narcotics for their pain management, but they experience opioid use disorder at a far lower rate than the general population. So it can't be that just taking opioids and just being prescribed narcotics leads to addiction. That's not the way it works pathophysiologically. And the most common causes of death of patients with sickle cell disease is not opioid overdose, is not opioid use disorder, it's not substance overdose. It is just the run-of-the-mill unfortunate organ complications that happen for patients with sickle cell because they have sickle cell disease. So acute chest syndrome, having pneumonia, dying from sepsis or infection. They don't have most sickle cell patients don't have a spleen, and so they're susceptible to different types of pathogens. Pulmonary hypertension, stroke. There are so many other ways, unfortunately, that can take the life of a patient with sickle cell. And substance use disorder and opioid overdose is rarely one of them. So I think the next point to understand is that patients with sickle cell disease are associating opioid use with suffering, as opposed to seeing opioids as a blissful escape or whatever people think happens when you're on a high or seeking drugs for things other than medical use. So for me, and I know I'm also speaking on behalf of so many other patients with sickle cell because I have heard them tell me these stories themselves, taking opioids is associated with going to the hospital, being really sick, having lots of pain. It's also associated with all the negative side effects that come with taking opioids, like constipation, fatigue, dizziness, nausea. Taking opioids is not a fun time. I feel like if I was addicted to a medication, I would be looking forward to something that medication can provide to me. I would be looking forward to something that the medication can give me that something else can't, and that I cannot survive without it. I want to take it. I desire that thing. And I will tell you with full 1000% confidence that people with sickle cell are not looking forward to take their opioids. They are not looking forward to being constipated. They are not looking forward to being nauseous. They're not looking forward to not being able to do their jobs or study the way they need to because they needed to take opioids because they're in pain and now they can't focus. We are not looking forward to taking opioids. We just do it because we have to. We take opioids because we'd rather suffer the side effects of this medication than suffer the extreme pain that we're having. And yeah, it really is not a positive, there's no positive correlation between sickle cell patients and taking narcotics. That to me, taking narcotics is the sign that I am unwell, and requiring narcotics is a sign that I am unwell, that I'm in a place that I don't want to be, and I would rather be in a place where I never had pain and never had to take narcotics. That's the reality. And I guarantee I'm not a mind reader. I am, not God. I don't know all the inner workings of people's minds, but I guarantee you that most patients with sickle cell will agree with me and that there's nothing fun about taking narcotics. We just do it because we have to. Okay, now that I've laid those foundations, we're going to go into some technical terms. So I think the fourth thing to really grasp is the difference between drug-seeking behavior as a result of having an opioid or substance use disorder versus other symptoms like tolerance, physical dependence, withdrawal, pseudo-addiction, and opioid-induced hyperalgesia. So I know I just threw a bunch of words at you, but I promise you they all mean something very important and they are very distinct. They are not interchangeable in any which way. So I'm going to go ahead and read the definition to you from an article that was published in 2021. And if I can just find it. Yeah, I started using Mendeley and it's changing my entire life. I absolutely love it. Okay, so I'm going to read through these terms that I just talked about. So, tolerance. Tolerance is defined as reduced potency of the analgesic effect of an opioid after repeated administration or the need for higher doses to maintain the same result. It shifts the dose-response curve to the right, indicating that a higher dose of opioids is required to maintain the same level of analgesia. I can't say that word. Okay, so another term is called dependence. And dependence, also called physical dependence, is a common and natural result of the body growing used to a drug or medication, particularly an opioid such as morphine. If the drug were suddenly stopped, the patient would undergo physical problems associated with withdrawal, also termed abstinence syndrome. It is easily avoided by reducing the dose of the drug gradually. It is distinct from addiction and tolerance. And then we also have opioid-induced hyperalgesia, which is defined as increased sensitivity to pain stimuli and pain caused by ordinarily non-painful stimuli, referred to as allodynia. Unlike tolerance, opioid-induced hyperalgesia worsens with higher doses of opioids. Lastly, this is really important, is pseudo-addiction. Pseudo-addiction is a syndrome of behavior and attitudes that emerges in patients who are not being provided with adequate analgesics. Physical dependence, addiction, tolerance, and hyperalgesia may become confused by healthcare providers and used interchangeably because these conditions may occur together in the active drug abuser. Drug-seeking behavior is rare in patients with sickle cell disease taking opioids under medical supervision, and the incidence of iatrogenic addiction is low. And iatrogenic means caused by medicine. So, I know that was a lot of words, so let me break it down to you. Basically, there are a certain set of behaviors and things that people will look for when they are assessing a patient for symptoms of drug abuse, symptoms of substance use disorder. But there are also symptoms that may be displayed by people who don't have substance use disorders and don't have any addiction, but might seem similar. That's where the conundrum is. If you're confusing someone's symptoms that are related to substance use versus someone else's symptoms that's not related to substance use, then how can you really discern the difference between the two? That's the point. Providers are not really good at doing that. Point blank. That's just how it is. The paper said it, I said it, other people with sickle cell disease have said it, other people with different chronic diseases have said it. It's hard to pinpoint the difference. I went to medical school and I did not learn any of this information, and I know that there are lots of clinicians who also lack this information based on the stuff that they literally tell me when they're trying to take care of me. Because there is this lack of clarity in ability to discern between tolerance versus pseudo-addiction versus physical dependence versus true substance use disorder, that can manifest in patients being misunderstood and misdiagnosed with substance use disorder when really the underlying problem is that they are undertreated or have grown tolerance to their pain medications and require more. And if you think about it, as someone who frequently needs pain medication, as you get older, tolerance is bound to increase. I was taking narcotics in my preteen years, and I need much more now to produce the same result. That's just how the body works. And after many days of having IV medication, if you just stop medication, you'll get headaches, you'll get withdrawal symptoms. Think about when you don't have your caffeine in the morning and you feel like you have a headache and you're groggy and you're irritable. That's the same thing. I didn't ask to need to be able to take this, but I have to. And so understanding that just because patients have withdrawal doesn't mean that they must be addicted. And just because they require more pain medication for this particular instance compared to the last doesn't mean they're asking you for pain medication just for fun. Understand that, y'all. And lastly, and honestly, I would say most importantly, is understanding the difference between medical discernment versus prejudice, bias, and racism in the era of the opioid epidemic. I don't know if y'all remember the war on drugs, Say No to Drugs, DARE, all of these initiatives that were put in place to, help get different drugs off the streets and out of people's hands. When I think about the war on drugs, I see that slogan and that initiative being taken advantage of and as an excuse for and the normalization of the police brutality and criminalization of Black people. Think about the show Cops and think about those campaigns that were the war on drugs. It was arresting people who had weed put in their possession. Things that are legal now are things you could have gotten arrested for in the past. That was the war on drugs. That was getting these super thugs off the streets and away from our kids and our families and our wives and our daughters because they're just unsafe. That happened a while ago. Now we're in the era of the opioid epidemic, and it's funny because it's the same problem, it's just a different drug, but now we see it as a medical problem. We see people dying from overdose, and so all of a sudden we are seeing these people that we previously labeled as drug users and just thugs and, not good for society. Now we're viewing them as patients. And if you think about the difference between the populations with the war on drugs versus the opioid epidemic, is that it's honestly the difference between black and white, the difference between those who are minoritized and those who are prioritized, those who are marginalized and those who are accepted as the norm. And the irony of the opioid epidemic is that it was built to help protect patients and take care of them and help them get out of their substance use issues. But at the same time, if you flip it on its head, it's being used to criminalize Black people, criminalize patients who actually need these pain medications. And so in all, different ways, patients with sickle cell, brown and Black people in particular, are always getting the short end of the stick. And I think it's really important for us to think about, as humans and as providers, who we decide is deserving of care, who we decide is a criminal versus someone who's just struggling. And I think that in the field of medicine, we like to criminalize people who are suffering from substance use disorders. And I don't think that's appropriate because it's a disorder, it's a diagnosis. It's not our job to police them, it's our job to help them. At the same time, we need to check our own biases and understand that clinicians are not trained to tell the difference between drug-seeking behaviors and the other symptoms of long-term opioid use that I described before. And if you are a clinician and you don't have a medical indication for the reason why you suspect this person may have a substance use disorder, then you might be letting your bias and your prejudice and even potentially racist rhetoric that you've grown up accepting as normal impact your clinical care. And that is very inappropriate. I just gotta say it. And nobody's perfect. We're all growing and progressing people, and I don't want this channel to be a place where I just talk trash about others, like this is how they did wrong. No, we all have room to change. I have biases too. Everybody does. You're not excluded, okay? Doesn't matter how good of a person you are or how much you try to learn about everybody's experiences. We all have biases because we all grew up in a world that has taught us to create shortcuts for different things. That's how our brain is wired. But if you use those shortcuts in a way that's not clinically appropriate, in a way that marginalizes people, in a way that denies certain patients care versus others, you're hurting people. And that's what ends up happening to patients with sickle cell disease. And I'm not saying that there is no patient with sickle cell disease that also has a substance use disorder. This is a world of infinite possibilities. Literally anything can happen. So I wouldn't be surprised if at least one patient with sickle cell has a substance use disorder. Like, that's just fact, just like anybody else could. But the key point here to take away is that substance abuse and substance use disorder is so much less common in patients with sickle cell disease than we are made out to believe. Just because someone takes narcotics doesn't make them an addict. Just because someone takes narcotics doesn't mean that they're actually not in pain. And I think it's really important that we recognize the difference between reality and the things that we have indoctrinated as normal. And we need to start doing better by patients with sickle cell disease and honestly by patients with other chronic illnesses that are often just like thrown away and neglected and just like, oh, whatever, you're fine. And I also want to speak directly to patients with sickle cell disease, directly to patients with chronic illnesses. If you are feeling like you are not heard, and you are questioning like, oh my gosh, am I really this horrible person? You're not. You're not. Your pain is valid. Your pain is valued. Pain kills. I see you, even if others don't. And I don't want you to feel like you are a burden for asking for the things that you need, because I know that happened to me. I genuinely started going into a tizzy thinking like, oh my God, do I really need this? Am I just some person who is just trying to game the system? Even though I know I wasn't, it's just so many people are telling me the same rhetoric. Every time I go to get help, I just get denied. I get told, you have a substance use issue, or you don't need that much. It really grates my psyche in a way that made me question myself. And thankfully I had friends and family to remind me like, girl, no. And I was like, oh yeah. And when I thought about it, I was like, I'm not. Like, this is just me. I'm trying to live my life. And so I'm asking for the things that I need. And so I just want to send an encouragement to those of you who feel like maybe there's an issue. You're not the problem. If you do have a substance use disorder or suspect that you do, definitely bring it up to a trusted person. But I don't have experience with it and I don't have knowledge on it, so I'm not going to address what could be done here because that's just out of my area of expertise. My area of expertise is sharing my experience with sickle cell disease, sharing my perspective with my dual identities as someone with sickle cell disease. I'm a patient. I've seen so many things as a patient, but also as someone who is training to be a doctor, training to help patients and provide care in that way. Being able to see both sides of the coin really gives me the perspective to share these things. And so I hope that you learned a thing or two. Definitely comment down below what was one thing that you learned from this video, and put what emoji we're going to use today, y'all. Put a pumpkin emoji because it's fall. Unpopular opinion, I don't like pumpkin, but still put the pumpkin emoji down below. Thanks for listening to my channel. Don't forget to like the video if you did. If you didn't, put a comment. Say what you didn't like. Let's have an honest, real discussion. I am always open to real discussion, accountability, all that good stuff, growth. So I'm here for it. Definitely subscribe if you want to keep seeing my videos. I will post videos every Wednesday at noon and sporadically at other times too. So if you want to keep seeing my journey about how I'm navigating life as a patient who used to have sickle cell but now is cured and surviving transplant or life post-transplant and trying to go back to medicine, all that good stuff, definitely stick around. And yeah, I'll see you next time. Thanks for watching. Toodles!